Welcome to all of you. My name is Heinz Hammer. I wish you a warm welcome also on behalf of my co-organizers, Jutta Keller, Mark Fox, and of all the contributing speakers. We want to thank you for your interest in the newest developments in the clinical and scientific fields covering various diseases and conditions which may be diagnosed by breath testing. We recently have completed development of a new European guidelines on the use of hydrogen and C13 breath testing, which are already or soon will be available online in the UEG journal. 45 clinical scientists from 18 European countries and 3 scientific societies, the ESNM, the EAGN, and the ESPGHAN, have contributed to this endeavor, which was made possible by financial support through a guideline development grant from the UEG. I would like to thank ESNM, Adam Pharma, and the organizers of this meeting for having entrusted us this podium, for spreading results of these guidelines and our recommendations. And I hope you will enjoy a fruitful and interesting symposium. The first presentation will be given by Jutta Keller. She has been very important for the whole guideline process, and she has overlooked both the hydrogen breath test guideline and the 13C breath test guideline, for which she took the main lead. And in her first presentation, she will inform us about referral for breath tests, which patients, which tests to use. Jutta, please go ahead.
Dear colleagues, I am going to present my talk about referral for breath tests, which patients and which tests, or in other words, which clinical characteristics make a patient suitable for breath testing, and what is the diagnostic armamentarium we currently have in the clinic. But first of all, my potential conflicts of interest. Hydrogen as well as C13 breath tests are non-invasive, relatively simple to perform and safe diagnostic tools. There are hardly any contraindications for hydrogen breath testing apart from very rare genetic diseases such as galactosemia, for instance. The marker substance used for C13 breath testing in the clinic are innocuous, so that hydrogen and C13 breath testing can be used in both adults and in children. If patients cannot undergo a C13 breath test, this is usually due to the fact that they cannot ingest the total test meal which is required, or that they react with an allergy to certain other substances in the test meal. The C13 urea breath test is an excellent test for diagnosis of Helicobacter pylori, and C13 hepatic function breath tests are used for assessment of various aspects of hepatic metabolism. The other C13 breath tests usually, and H2 breath tests also usually used in GI, are tests of GI function. They can be used to investigate patients with chronic, unspecific GI symptoms, for instance, abdominal pain, nausea, vomiting, bloating, flatulence, diarrhea, or constipation. And these symptoms are extremely prevalent. They affect about 30% of the European population to varying degrees. If these patients are investigated, more than 50% turn out to have functional disturbances and are therefore candidates for our breath testing. However, breath testing rarely is the first test which comes in mind when investigating or when dealing with a patient with chronic abdominal complaints. Because the symptoms are unspecific, we do need other tests to exclude structural, morphological, infectious, chronic inflammatory, or even malignant disease. This particularly holds true for patients with alarm symptoms. It is difficult to define what minimum number of tests actually means because we have a broad armamentarium of other tests, including upper and lower GI endoscopy, imaging techniques, and laboratory investigations. It actually depends on the patient's characteristics and on concomitant diseases and on severity of symptoms, whether the breast test can be performed rather early in the diagnostic algorithm, or whether it is something we think about rather after performing extensive other tests. This is particularly clear for lactose malabsorption. This slide shows the worldwide prevalence of lactose malabsorption, and as you can see, lactose malabsorption is rare, as shown by these red colors, in the northwestern parts of Africa, but much more prevalent, affecting 70 to 100% of the population in South Africa and large parts of Asia. Even in Europe, there is a marked north-south divide, with hardly any patients with lactose malabsorption and lactose intolerance in some northern European regions, whereas the prevalence of lactose malabsorption and lactose intolerance reaches up to 70% in, for instance, Greece and South Italy. Therefore, it is extremely important to know the origin of a patient's family to decide whether lactose malabsorption is a likely cause of a patient's symptoms and whether to introduce the breast test or not. It usually does not suffice to just ask the patient whether he or she tolerates lactose, because about 50% of subjects are not aware of an association between lactose and symptoms. Concomitant diseases also markedly influence pre-test probability of certain functional disturbances. These data are derived from a study using a national US database search engine with almost 44 million electronic medical reports. As you can see, a little less than 70,000 patients were diagnosed with gastroparesis. Of these, very few, 0.05%, had idiopathic gastroparesis with no predisposing disease, whereas 1.3% of patients with type 2 diabetes and almost 5% of patients with type 1 diabetes were affected by gastroparesis. Accordingly, the relative risk of patients with type 2 diabetes was increased by a factor of 26, that of patients with type 1 diabetes even by a factor of 92, as compared with patients without predisposing disease. Other factors which also will influence the decision whether and when to perform a breast test are practical considerations, availability of tests, invasiveness, costs, and these also depend and vary with the respective healthcare system. These are the clinically available hydrogen and C13 breast tests that we discuss in our guidelines. For hydrogen breast tests, we have lactose and fructose hydrogen breast tests for diagnosis of carbohydrate intolerance. Glucose and potentially lactulose breast tests can be used for diagnosis of small intestinal bowel overgrowth, and lactulose is an option for measurement of oral fecal transit time. For C13 breast tests, the guidelines discuss C13 urea breast test for diagnosis of H. pylori infection, gastric emptying breast test with various substrates, the C13 mixed triglyceride breast test for measurement of pancreatic exocrine function, various liver function breast tests, and other tests which test non-GI functions, such as the C13 glucose breast test for measurement of insulin resistance, and certain C13 marked substrates with which we can measure the metabolism and expected toxicity of certain drugs. The individual indications for breast testing, as discussed in our guideline, are as follows. Hydrogen breast tests for carbohydrate intolerance are established in patients with intermittent diarrhea, abdominal pain, bloating, distension, nausea, and flatulence. if these patients have no evidence of organic disease on appropriate investigations. The role of hydrogen breath test for diagnosis of SIBO is less clear, but since there is no real gold standard for diagnosis of SIBO, the glucose or perhaps lactulose breath test can be considered in the presence of bloating, abdominal discomfort and flatulence, and/or signs of malabsorption. The time between the ingestion of an unabsorbable fermentable organic compound, such as lactulose or inulin, and the rise of H2 concentration in expiratory breath can be used to estimate oral cycle transit time. However, the guidelines only give a moderate recommendation for use of the lactulose H2 breath test to demonstrate the effect of a pharmacological intervention on gastrointestinal transit, whereas most of the experts felt that there is no clear indication for the test in clinical practice. For the C13 breath test guideline, we derive general indications for H. pylori testing, performance of gastric emptying tests, pancreatic function and liver function tests from established international and national guidelines as available. And then we defined the role of the respective C13 breath test for H. pylori testing or testing of GI function. The H. pylori testing is highly recommended in adults with suspicion or evidence of peptic ulcer disease, atrophic gastritis, MOLD, for instance, for the test and treat strategy in an investigated dyspepsia, and for exclusion of H. pylori gastritis before reliable diagnosis of functional dyspepsia. In children, there is a high recommendation for performance of H. pylori testing, again in subjects with suspicion or evidence of peptic ulcer disease, and for monitoring of outcome of eradication therapy. In all these cases, the C13 urea breath test is to be considered as a non-invasive alternative for H. pylori diagnosis if endoscopy is not required or if biopsy are contraindicated. It is a preferred option for confirmation of H. pylori eradication in adults and children. C13 gastric emptying testing is an option for measurement of gastric emptying in patients with suspected gastroparesis. Gastric emptying tests in general are recommended in symptoms suggestive with gastroparesis who do not have evidence of mucosal or structural disease explaining these symptoms. The same holds true for children, but the spectrum of symptoms is slightly different. There is a moderate recommendation for patients with suspected dumping syndrome for measurement of gastric emptying, and again, the C13 gastric emptying breath tests have been shown by validation studies to be a valid alternative to scintigraphy as the reference test for measurement of gastric emptying velocity. Pancreatic function tests are recommended, for instance, by the European guidelines on chronic pancreatitis in adults with suspected pancreatic exocrine insufficiency, for instance, in those after pancreatic resections or with suspected chronic pancreatitis. There is a moderate recommendation for monitoring of pancreatic enzyme replacement therapy for patients with chronic diarrhea as a differential diagnostic approach. In children, again, the pancreatic function tests are highly recommended if in patients with chronic pancreatitis at regular intervals, in newly diagnosed cystic fibrosis, and for monitoring of pancreatic function in patients with cystic fibrosis who still are pancreatic sufficient at the time of diagnosis. The C13 mixed triglyceride breath test again has to be regarded as an established alternative to other non-invasive and invasive pancreatic function tests. For C13 liver function breath tests, there are no general recommendations. They could be used for measurement of various aspects of liver function in adults, whereas presently, due to the very limited evidence, performance of C13 liver function breath tests for clinical reasons in children cannot be recommended. To summarize, hydrogen breath tests with lactose or fructose are established clinical alternatives and in most cases the best clinical alternative for assessment of carbohydrate intolerance. They also require symptom assessment. The glucose H2 breath test is probably also the best clinical option for diagnosis of SIBO. However, there is no true gold standard, and also breath testing has various and marked disadvantages for diagnosis of this condition. For lactulose breath testing, the clinical role is less clear. The lactulose H2 breath test reflects oral-fecal transit time, but there is a high variability of oral-fecal transit time intra and inter-individually, and there's a large overlap with diagnosis of SIBO, and therefore the clinical role of this test is less well defined. For C13 breath testing, the C13 urea breath test has the highest accuracy among non-invasive H5 breath tests and is recommended in adults and children. The C13 gastric emptying breath test is an accepted alternative to gastric emptying scintigraphy, also in adults and children. The C13 mixed triglyceride breath test can be used as an alternative to diagnose pancreatic exocrine function in patients of all ages. And for measurement of liver function via breath test, it can be said that the results correlate with histology in adults, but these tests are used in highly specialized centers only, at least so far, and they are not recommended in children because of lack of data. Coming back to our initial questions, which patients, which tests? We can summarize that breath tests are useful diagnostic tools in adult or pediatric patients with chronic bothersome GI symptoms. However, relevant organic diseases have to be excluded before function testing. The type and number of investigations depend on patient characteristics, invasiveness, and availability of tests. Hydrogen breath test used for diagnosis of carbohydrate intolerance or SIBO, and the C13 mixed triglyceride breath test used for diagnosis of pancreatic exocrine insufficiency may be particularly helpful in patients with chronic diarrhea, abdominal pain, bloating, or signs of malabsorption, whereas C13 gastric emptying breath test and perhaps the lactulose H2 breath test may be the best way forward in patients with dyspeptic symptoms and signs of severe intestinal motility disorders. However, symptoms are unspecific, and it does make sense to also use the other tests in patients with inconclusive results. Thank you for your attention.